Okay, thank you, Lawrence, for that wonderful. Sorry, guys. Thank you, Lawrence, for that wonderful introduction. It truly is a great honor and a great privilege to be here with you today. So the title of this talk is Postpartum Hemorrhage, a Hematology Perspective. So before we start, some disclosures first. I'm currently lucky enough to be a recipient of some funding from the NIH. I previously received consultancy fees from CSL Behring, and lastly, I have some material support ongoing from Hemanetics. The other important disclosure is, just for clarification, I am an obstetrical anesthesiologist. Dr. Drusen had his tongue in his cheek, so even though this is a talk on transfusion, I'm not a transfusion medicine expert per se, but I do have interests in PPH and transfusion management for PPH. So for the purposes of this talk, what we'll do is initially look at trends and some recent epidemiology associated with the transfusion management of patients with PPH. We'll then move on to some interesting new changes that we've made to our labor and delivery unit for blood ordering practices for patients who are admitted, who are pregnant. And then we'll move on to the meat of the talk, which will be looking at transfusion aspects for managing patients with obstetrical bleeding. And we'll spend some time looking at the massive transfusion protocol that has certainly revolutionized our practice at Stanford. Last but not least, we'll look at some novel and some new approaches for how we can consider changing up our ways for managing transfusion. So let's make a start. And what we can see here on this slide is a graph that's been published by investigators at the CDC. And what we can see here is that there's been a slow but steady increase in the rates of postpartum hemorrhage in the US between about 1994 and 2006, and that's depicted by the top line on the slide. Now, the main driver for this, as you heard from Dr. Drusen, is uterine atony, and if you look at the middle line, you can see that the rates of atonic postpartum hemorrhage mirror that overall for PPH. So obviously, if there's growing concern about increasing rates of postpartum hemorrhage in the US, not surprisingly, people are worried about the fact that we may well need to transfuse those patients that have severe postpartum hemorrhage. So what do we know about the risk factors for those patients with severe postpartum hemorrhage that require transfusion therapy? Well, this is some interesting data that's been published by Brian Bateman and colleagues from Mass General. And what they did was they looked at a large nationwide data set to look at independent predictors for patients with postpartum hemorrhage that require transfusion. And now these patients all had uterine atony as well as their underlying etiology. And what we can see here is there are some differences based upon age. But importantly, what you can also see is that delivery type also influenced the risk profile. So patients who underwent cesarean section were at higher risk than those patients that underwent vaginal delivery. And in fact, the highest risk group were those patients that had labor that preceded cesarean delivery. As you heard earlier, there are important risk factors associated with atony, and these are similar to the risk factors that we can see are associated with atony that led to postpartum hemorrhage that resulted in transfusion. Now, I'm going to emphasize the importance about mode of delivery in terms of the risk associated with severe postpartum hemorrhage. So this is similar data that's been published from a slightly different geographical region. This is from Scandinavia, but they found very similar results to that in the Bateman study, where patients who underwent emergency cesarean section were at the highest risk of severe postpartum hemorrhage. So this is bleeding that was equivalent to or greater than 1,500 mils, or patients that had a postpartum hemorrhage plus transfusion. So the take-home message here is that if you're dealing with a patient that needs to go back to the OR for an emergency cesarean section, and if they have additional risk factors for uterine atony, then we need to be particularly careful about the risk of severe PPH and the possibility of them needing transfusion. Now, as you heard earlier, there are obviously other important antenatal risk factors associated with severe bleeding, and these include previa and abnormal placentation. I won't dwell on the details because you've heard some of this already, and you'll hear more in the next lecture. But suffice to say that these patients are at severe risk of high bleeding or high rates of bleeding, and obviously consideration for transfusion therapy is probably worthwhile. So we're going to move on to some interesting new aspects that we've adopted at Stanford in terms of blood ordering practices. And we've sat down with our obstetrical and transfusion medicine colleagues to sort of review where we were going and where we should be in the future in terms of blood ordering practices. Now, the reason why we did this was that we felt that there was a lot of patients who had minimal or low risk factors for postpartum hemorrhage that are undergoing unnecessary type-in screens. And this has certainly been studied previously in the literature. So based upon this, we stratified patients according to their level of risk based upon our clinical experience and what we knew from the literature. And what we felt was that we should abandon the type-in screen process of patients that had no or minimal risk factors for postpartum bleeding, and instead these patients get an ABO-RH test on admission. Obviously, there are patients that do have risk factors for postpartum hemorrhage, and obviously we'll consider alternative practices. So patients who are defined as being at medium risk will get a type-in screen, and these will include patients with a history of prior PPH or transfusion therapy, abnormal antibodies, or who have important or relevant antenatal or intrapartum risk factors. And you can see examples of those on the slide. If patients require general anesthesia for scheduled cesarean section for either medical or obstetrical indications, then also we'll consider a type-in screen for these patients, as we know that these patients can have a greater degree of blood loss than those that undergo a regional anesthetic. Now, obviously, there are patients that are determined to be at high risk, and we've heard about some of these already, so patients with previa or abnormal placentation, and for these patients, we'll consider a type-in cross. Less commonly, you may encounter patients that have severe pre-delivery anemia on admission, so maybe a hemoglobin of 8 or 9 or less, and obviously an average amount of blood loss may cause them to be severely anemic after delivery in the postpartum period. So these patients may also be candidates for a type-in cross on admission. And then less commonly, patients who require therapeutic anticoagulation or whom have inherited or acquired bleeding disorders may also warrant a type-in cross. And bear in mind, obviously, that there's a moderate heterogeneity in terms of the risk factors for postpartum hemorrhage. So if patients have 2 or more risk factors for PPH, if they're moderate, then we'll also consider a type-in cross. So why did we do this? Well, what we did was that we assessed the blood ordering practices 3 months before we implemented this quality improvement, and then we compared it to the 3-month period afterwards. And what you can see here is that there's a drop-off in the number of patients that required full antibody screens, and then we saw a decrease overall in the total number of diagnostic tests. So this made life a lot easier in terms of the volume of work for patients that required some form of type-in screen. We didn't see as many patients needing them afterwards as opposed to before. And this also led to a decrease overall in hospital charges. So we can see here that approximately about $100,000 was saved over the 3-month period after quality improvement, and obviously this translates into a much larger figure that will occur over time. Now, obviously, you need to consider your catchment population, the level of risk that your patient population has on your labor and delivery unit. So I'm not suggesting that you follow our guidelines, but it's just something to think about in terms of what blood ordering practices may be relevant to your patient population on your labor and delivery unit. So let's move on to the meat of the talk, which is obviously dealing with transfusion for patients that have invariably severe, anticipated or unanticipated bleeding. And obviously the biggest problem that we face is deciding when or if to transfuse. And this obviously is very challenging. And you can experience a Homer-like moment where you get a bit stressed out, uncomfortable about whether you should hold off or whether you should actually call for some form of blood product to deal with major bleeding. So it's actually pretty difficult. And overall, it's really hard for us to determine what really are the best criteria for transfusion. And there's no good consensus. So as a result, we rely upon our clinical experience and our clinical discretion to really determine the timing and the nature of transfusion. So there are some clinical endpoints that we can consider. We may consider what the prior rate and the ongoing rate and magnitude of blood loss has been. We may look at the maternal vital signs and see what they've been doing and where they are now. But bear in mind that patients can decompensate fairly late in the game because of the physiological effects associated with pregnancy. So you want to be a little careful here if you want to wait and wait and wait, because you may find that from a cardiovascular standpoint, patients can decompensate right towards the end, which is the worst time to do it. You may want to think about maybe ordering some labs and waiting until you get the hemoglobin or the hematocrit level back. But obviously, if you're dealing with a patient that's suffering from severe and ongoing bleeding, you may not have the luxury of time before you get the hemoglobin or the hematocrit level back before you determine whether that meets a transfusion trigger or not. Last but not least, and I can only reiterate what Dr. Drusen said, make sure that you liaise closely and regularly with your obstetrical colleagues, because they should be able to give you an idea about what the etiology of bleeding is and give you a handle on their current status with regard to the degree of surgical control. And this is really important because it gives you a good idea about whether you should transfuse and also gives you an idea about what the degree and the severity of volume resuscitation may be. Now, estimating blood loss is actually pretty difficult, and none of us are very good at it, as you heard earlier. And there's some data that seems to support this based upon simulation studies. So this is some data that's been published by investigators at Northwestern, led by Paloma Toledo. And what we can see here, if you look at the top graph, is that we generally aren't very good at estimating blood loss. And in fact, as the blood loss increases, our estimates get worse, and we tend to underestimate rather than overestimate. Now, there may be interventions that we could consider to try and counter this. One of these may be the use of calibrated drapes. And you can see an example of what a calibrated drape looks like on the slide. So this is a drape that has volumetric markings on, so you can get a better handle on the volume of fluid or blood that's contained within the drape. And what they found in this study, which is a simulated vaginal delivery study, was that when investigators or when respondents were asked to guess the volume of blood in the calibrated drapes, they did better than those that guessed the volume within non-calibrated drapes. So obviously there may be some value here, but bear in mind if you're going to use these during a cesarean section, then you have to try and differentiate the amniotic fluid from the blood in the drape, and also any irrigation fluids that may be used by the surgeon. So I don't know whether the use of these drapes is as good for a cesarean section as it might be for a vaginal delivery. So determining when to transfuse can be difficult, and we know that estimating blood loss is challenging. So maybe we should consider algorithms or heuristics or rules of thumb. Maybe that's a better approach. And there's certainly many examples of these that you can find in the literature, be it based upon institutional data or maybe local data, region-wide, statewide, national, or even international guidelines from various bodies or societies. And these may have some value. So what we can see here is an example of some guidelines that's been published by the CMQCC. Now, as you heard, this is a body that's been convened by the Department of Health in California, which comprises a series of experts in OB, anesthesia, and perinatology. And these experts have sat down to come up with a series of guidelines for obstetrical complications, such as obstetrical hemorrhage. Now, as you can see, this is a very busy slide, and it's very text-heavy, but it is very comprehensive. So looking at this in the cold light of day is fine, but one wonders how useful it might be if you're trying to refer to this in the heat of the moment. Now, the reason why I put this slide for this talk is that it does contain some information about transfusion therapy, and I apologize for those at the back that may not be able to see the text. But what I've highlighted here is what they recommend for a patient that has a blood loss of 500 cc's or more after a vaginal delivery, or those that have 1,000 cc's or more after a cesarean section. So what they initially recommend is type and crossing for 2 units for those patients. If the bleeding continues, then giving those 2 units and consideration for thawing FFP. And if the bleeding gets more severe, what they recommend is aggressively transfusing as opposed to non-aggressively transfusing. Does that mean you've got to do it angrily? I'm not quite sure. But anyway, aggressively transfuse and give red cells, FFP, and platelets, and then mobilize a massive transfusion protocol as necessary. Now, these guidelines are very reasonable, but obviously bear in mind if you're dealing with someone who is suffering from severe ongoing bleeding, or that may have moderate blood loss to start with, and then transitions to severe bleeding, then this may be an issue. Because if you order a type and cross, and then you realize, actually, I need to change my mind because the bleeding is really bad, I want to order O negative or activate the massive transfusion protocol, this can potentially lead to some problems with communication between you, your providers on the labor and delivery unit, and also the technicians in the lab. So just be careful here in terms of the order that you make initially, because you may need to change it later on in the game, depending upon the severity and the acuity of bleeding. So maybe the best approach is, if you're really worried earlier on, making sure that you have good early availability of sufficient volumes and types of blood products. And one would argue that in this case, the early bird certainly gets the worm. So we've implemented a massive transfusion protocol in obstetrics at Stanford, which I would say has certainly revolutionized our practice when we're dealing with a patient that has major bleeding, be it anticipated or unanticipated. Now, this was inspired because of a protocol that was implemented by our trauma surgical colleagues along with our transfusion medicine colleagues. And we basically implemented one specific to obstetrics. The key advantages of the massive transfusion protocol are that we get early availability, I repeat, early availability of sufficient volumes and types of blood products. It establishes effective lines of communication between you, your colleagues on the labor and delivery unit, and also the technicians in the transfusion services department, but it does require a significant amount of time to implement, and you need to liaise closely with all the relevant parties that may be involved in actioning the massive transfusion protocol. When it works really well, and the main factor here is that you can get blood issued within a very short period of time, which is a maximum of about 10 minutes after the order has been made. Sorry. So what does the pack contain? Well, in the literature, there's certainly a lot of different variations in terms of the contents of the pack. And I've seen 661, 441, 442. Some of the packs contain cryoprecipitate. Some of the packs also contain recombinant factor 7A. But what I can tell you is what our pack contains at Stanford. So ours contains 6 units of O-negative blood or type-specific blood. 4 units of liquid plasma. So this is plasma that's stored at room temperature. It's pretty similar to fresh frozen plasma, but it does have a slightly lower concentration of factor 8. But for all intents and purposes, it should equally be as effective. The lab also has 4 units of thawed fresh frozen plasma that are available at any one time, which they can give us based upon knowledge or prior knowledge of the patient's blood type. And lastly, the pack also contains 1 apheresis unit, 1 apheresis platelet unit. Now you can see on the picture on the slide that we have here a cooler, and the red cells are in the cooler, and the platelets and the FFP are actually on top. So bear in mind that obviously the platelets and FFP need to be on top, outside the cooler. The red cells go in, and there's a sticker on the box that reminds us of that. So how do we order the MTP? Well, it's nice and simple. When you decide that you need the order, you pick up the phone and you say the words, activate the massive transfusion protocol. So it's nice and clear. Everyone knows exactly what you want. So when you do that, then what happens is you send a runner down. So this is someone who's not involved in the management of bleeding, who has a call slip. So what is a call slip? It's basically a sheet of paper that has patient identifying information on it so that the lab knows to whom the blood will be going to. When they get down to the transfusion services department, they exchange the call slip with the caller. The runner comes back to the labor and delivery unit, passes off the caller to you with all the products, and then depending upon what you think the severity of bleeding is, you can reactivate the order, and the runner goes back downstairs to get another pack as necessary. So it's great because if you need a large volume of products, you can keep the cycle going until you've got good surgical and hemostatic control of the bleeding. So it really is a lifesaver, especially if you need a large volume of products over a very short period of time. Now, we've historically done this with a verbal order, but with the advent of the electronic medical record, obviously everything is becoming more electronic in terms of the ordering process. So certainly at Stanford, initially we have to activate the order electronically with Epic. I don't know what electronic medical record system that you have at your hospital, but I'm sure many of you use Epic. So on the picture, you can see one of our fellows who's happily ordering the MTP, which we did, in fact, on Tuesday for a patient who had a placenta accreta who underwent cesarean hysterectomy that required major transfusion. If you're doing it electronically, you do need to confirm the order by making a phone call afterwards, though. So this is some pictures that I actually took during the course of the cesarean hysterectomy. So this is a slide that I took of all the products that we used within about, I'd say, half an hour, 40 minutes of the onset of bleeding. So you can see here there's a number of different bags of red cells, FFP, and platelets. There's also some crystalloid as well that you can see in the background. This is about an hour or so after the onset of bleeding. You can see the pile of bags is much bigger. So as you can tell, the blood loss was pretty severe that we had to deal with. And in fact, this patient ended up requiring about 30 units of blood, 15 units of FFP, and at least a couple of units of platelets. That's not including any other synthetic products that we gave. So bear in mind that you may start off with cross-matched blood at the start of a scheduled case, like an accretor, but if the bleeding ends up being severe and acute after the onset, you may find that you need large volumes of products very quickly after you've used up the cross-match units. So you may find you need to activate the MTP, even for a scheduled case that you thought you would have sufficient volumes of units to start with for. So this is another huge advantage of the MTP. If you're trying to stay ahead, that's fine. But bear in mind, you don't know how long the lab is going to take if you really need the products quickly over a very short period of time. So having a resource like the MTP can be really life-saving, even for a scheduled high-risk case like this. So the other importance about the MTP is the timeline. I think I mentioned this a little earlier. And Tim Goodnow, our guru in the Transfusion Services Department, will provide us with O-negative blood that's emergency released within about 10 minutes. Now, as you can see on the slide, this is much sooner and quicker than we expect with type-specific blood, and certainly much quicker than you get with Coombs negative or Coombs positive cross-match blood. So what you've heard so far is how we implement the MTP and how we action it. What do we know about outcomes in patients for whom the MTP is activated? So this is a study that we published last year in IJOA, which provides you with at least a flavor of the units that we use for patients who actually have the MTP activated. Now, what I'm going to just show you here is the fact that there's a large majority of patients for whom they received at least one product of blood, one unit of a blood product from within the MTP. This amounts to about 80% of the patients utilizing at least some form of blood product after the MTP was activated, which suggests that we're pretty good at appropriately activating the MTP. You'll note that there are some patients here that required a large volume of products, which included patients that required equal to or greater than 9 units of red cells, plasma, and platelets. What about hematological changes that occur in patients that require the MTP? Well, again, this is a table that we published in a study, and what you can see here is before the MTP is activated at baseline, so even before delivery, the hematological and coagulation indices look pretty acceptable. And then we took labs during the course of the bleeding, and as you can see, some of these are pretty extreme. You would expect, obviously, the hemoglobin to drop, the platelets to drop, the INR and the APTT to go up, the fibrinogen to go down, and the pH to decrease as well, which is what we found when we looked back over time. But the good news is that after resuscitation, so after bleeding had stopped, with the use of the MTP products, we managed to normalize a lot of these indices or get them back into an acceptable range of values. Now, obviously, I accept that we didn't compare this to a group of patients that didn't receive products from an MTP, but nonetheless, it gives you a flavor for the fact that the MTP for these rare but high-risk patients that bleed a lot may be of some good clinical value. You'll know that the EBLs for these patients were often quite high. The median value was around 2,800 cc's. So for the last part of the talk, what I thought we'd do is touch upon coagulopathy and PPH. Now, certainly I would agree with Dr. Drews, and sending off coagulation valves immediately is probably not the best thing to do, but when you're dealing with a patient that has ongoing and severe bleeding, then it probably is a good idea to consider any coagulation and hematological disturbance during the course of ongoing bleeding. So one would argue that it's probably worth sending the labs fairly early, not immediately, but fairly early, and regularly, so you can assess the trend of change over time in any coagulation or hematological disturbance that occurs. So the indices that you want to identify are a low fibrinogen level, and I'm going to emphasize the importance of this later on during the Sam Hughes talk, a decrease in the platelet count, evidence of disseminated intravascular coagulation, and also hypocalcemia. Now, what you'll often find when you're dealing with a patient with severe ongoing bleeding, like the accretor patients or the incretors or the percretors, is that the calcium level can plummet and stay really low, especially if they're requiring massive transfusion therapy. So it is a good idea to have calcium chloride or calcium gluconate in the room in order to try and counter this. Bear in mind also that there's pathophysiological disturbance that can occur during the course of bleeding. So obviously any coagulation disturbance may be aggravated by a decrease in patient's core temperature and also a decrease in the patient's pH. So using active warming is certainly a good idea, and if you identify acidosis, you may need to treat this or correct this with bicarbonate as necessary. Now, there has been a lot of controversy, as I'm sure many of you are aware, about whether we should be using strict ratios of red cells to other products, notably FFP. And this has been a source of considerable debate in the literature, and whether this applies to when we're dealing with transfusion therapy for patients who experience major bleeding. Now, much of this work stems from the trauma literature, and certainly in the late 2000s, there was a number of studies in the trauma setting which appeared to suggest that if you use high ratios of plasma to red cells, this might be associated or is associated with a decrease in mortality in patients that incur traumatic hemorrhage. So obviously a lot of people got very excited about this because of the improvement in patient outcomes amongst patients that incur traumatic hemorrhage. However, and this is a big however, on further review there was a number of important and major concerns with the statistical and scientific validity of the data that's been published. Now, I'm just going to highlight the main concerns that a lot of people found. In the trauma setting, these studies were retrospective. Some of these studies had important missing data in a number of these papers, and one of the biggest issues was with regard to survival bias. So what they found was that for patients who were admitted to the ED or the trauma unit who ended up surviving much longer than those that died, not surprisingly, they got more units of FFP, and as a result, their ratio of FFP to red cells was much higher. So there may be an important bias here in a number of these studies in terms of the time period of resuscitation and how that impacted upon the number of units of red cells and FFP these patients received. The other thing to bear in mind is that these patients are generally young, fit males that experience penetrating trauma, and they're from either the military or civilian populations. And obviously that's very different from the type of patients that we see on the labor and delivery unit, who obviously have a different coagulation profile at baseline compared to those within the trauma setting. So with that being said, do we know of any potential benefit in using high ratios of FFP to red cells when we're dealing with transfusion for someone who's undergoing major bleeding? Well, the answer is not really. There's only been one paper that's come out very recently in ANA. This is from France and was a retrospective data looking at a very small cohort of patients who experience severe bleeding that require transfusion therapy with red cells and FFP. And what they found was that those that received a high ratio of FFP to red cells were found to be associated with a reduced risk of requiring medical intervention like arterial embolization or more invasive surgical intervention like hysterectomy. They used propensity matching and an inverse ratio, which is why the odds ratio is higher than what you would think. But bear in mind, this is a retrospective study. This cohort's very small, and they didn't account for the timing of administration of these units. So we don't know if the patients actually received 1 unit of red cell to 1 unit of FFP during the course of resuscitation. They assessed overall the number of units that were transfused and the ratio as a result. The other thing to bear in mind is that when we're talking about other products, so non-red cell based products, that the fibrinogen concentration is very variable per unit or per pool. So the fibrinogen concentration in FFP is much lower than you get with cryoprecipitate. So one wonders whether, if we're considering a ratio of red cells to something else, we should be thinking about cryoprecipitate, certainly if we identify patients as being or having a very low fibrinogen level. But unfortunately in OB we have no data to indicate whether giving red cells and cryoprecipitate improves outcomes as opposed to red cells and FFP. So for the last part of the talk, we'll move on to goal and targeted directed therapy. And you heard yesterday from Jennifer Lucero about the potential clinical value of using these point-of-care devices. So on the left you can see a TEG machine, and on the right you can see a ROTEM device. And I think she put up a very similar slide yesterday, which appeared to suggest that there's some value here in looking at these parameters for a number of reasons. You can assess the efficacy of your transfusion therapy, and it also may be useful in terms of goal-directed therapy. So on this slide, we have 4 traces that you get from a ROTEM. The top 2 are before therapy, and the bottom 2 are after therapy. And on the top right-hand slide, this is a Fib-TEM trace. So this gives you information about the fibrinogen component to clot formation. And it looks pretty skinny, and the reason why is it's measuring maximum clot formation, MCF. So this is in a patient that's bleeding, and you can see it's a skinny-looking trace that looks like the fibrinogen component to clot formation is actually pretty poor. So what this suggests is that this patient needs some form of fibrinogen supplementation. So this is exactly what they did, and the bottom two graphs are after the fibrinogen has been supplemented. And as you can see, the bottom right slide, the MCF on the FibTem looks a lot fatter, which is what you would want after you've given fibrinogen supplementation. And this confirms that hopefully it appears to be working pretty well. So obviously it's early days. We hope to see more studies appearing in the obstetrical literature that will hopefully provide us with more useful information about the value of using these types of devices for trauma therapy for patients with bleeding. The other thing to look out for are two important studies that are still ongoing. I think they're actually close to completion. The first study is looking at the value of fibrinogen concentrate. So this is plasma-derived. It's a lyophilized powder that you can give as a slow injection in patients who experience hemorrhage. And there's a major study happening right now in Scandinavia to investigate the value of this as opposed to a placebo. And the second study is the Big Woman study, which some of you may have heard about. In this study, they're looking at the value of tranexamic acid to see whether that reduces mortality in patients with PPH. And this is a big study. It's a whopper. It's an international multi-center global study. And I think we'll probably see data from both of these studies appearing in the next year or two. So we're coming now to the end of the talk. So just to conclude, in the US, we've seen increases in rates of postpartum hemorrhage, and it might be the case that the main driver for this is uterine atony. Be careful if you're taking a patient back to the OR who's experienced a trial of labor, who has other risk factors for atony, because it's likely that they are at increased risk of severe bleeding. We're not clear about the clinical indicators for transfusion, so use your clinical experience and discretion. But there's certainly great value in considering a massive transfusion protocol if you deal with patients who have major bleeding at your institution. It provides you with sufficient volumes and early availability of all the products that hopefully you'll need, certainly during the initial phase of resuscitation. And last but not least, there are point-of-care devices that may have some value in the future for goal-directed therapy. And with that, I think we'll call it a day.